Uh, you learn all the palliative care and pain management in the course. You start practicing the use of the WHO ladder. You manage to get your recognized medical institution status to procure morphine, and you start practicing it. And unfortunately, you will find that about 1/4 of your patients will not, may not get good pain relief, satisfactory pain relief by using the WHO pain analgesic ladder. Sorry to discourage you. That's the reality. About 3/4 of the patients get satisfactory pain relief. Some of them have excellent pain relief. I don't know if I've told you this. I've had an architect taking, with cancer of the pancreas, taking morphine and living to complete his project. She sent me a photograph at the day of the opening of the apartment building with his daughter standing in front of the building. I've had a lawyer practicing law for more than a year while taking 600 milligrams of morphine a day. So a lot of people can be functional and enjoy life on the ladder, but 1/4 of patients may not. Today's talk is about trying to get them relief, the 1/4 of people who are left behind. I shall look at it, and Raju will be sharing these slides with you in 3 stages. One, okay, the person does not have pain relief. Preparing ourselves, reviewing everything that we did, and then going on to 3 steps of effective management. This is what we'll talk about. You don't have to remember everything in the picture now. We will talk about it later. Now, starting with the first one, what do I mean by preparing? Uh, the first point is, when we are unable to relieve somebody's pain, we are likely to get upset. We don't like to admit it, but the moment the patient comes from there, you start thinking, oh God, there he comes again. We have to deal with that. You and I are only doctors. We are not gods. We cannot solve every problem. Our job is to try our best. When we believe that, we'll start blaming the patient. Because if you don't accept this failure, what will you do? Hey, have you been taking all the tablets I gave you? Yes, doctor, except that on Friday I forgot it once. And then you pick up on that. Oh, how can you get better if you don't follow my advice? Subconsciously, we may tend to shift the blame to the patient. Start by believing the patient. Usually, patients are telling you the truth. Rarely, they may tell lies to get a few days of leave or to get a certificate from you. But we don't start with that assumption. We start with the assumption that the patient is telling you the truth. In preparation, first step, pain is not easily controlled. We start by believing the patient. 2, are we just using the ladder? Are there other things to do? Keep reviewing the patient. One thing that happens to me, I have evaluated a patient. I know his condition. And next week, when I see him, I may assume that his condition is the same as last time. The patient came to you with chest pain. Okay, you very cleverly diagnosed the tumor plus an eroded rib, did the necessary thing. And today he says, I still have bad pain. It's worse than before. You assume that it is still the old condition. Now he may be having a pleural effusion. Pleural effusion causes a dull kind of severe pain. So keep reviewing. It is not only about the ladder. Pain management is not only about the ladder. It's about other measures of treatment also, like those interventions. If I have a erosion in the rib, what would be the best way of treating that pain? Anybody? Raju, please look at the chat box.
Intercostal nerve block.
With local anesthetic,
Yeah.
uh, how long will that help, doctor?
Sometimes.
That's a very good measure for immediate relief. But if it is really an erosion of the rib, then the effect is, I mean, if it was a chronic pain, it may be expected to last long. But as soon as the pain, local anesthetic wears off, it may come back. There is a possibility of giving neurolytic blocks, but for peripheral nerves, they are of questionable value.
Mhm.
But here, look at the screen. The best way of relieving that pain is radiation. If the radiotherapist, the radiation oncologist, gives a single dose of fraction, that can be the best way of not only relieving that pain, but also of making sure that you are not making sure, reducing the chance of a fracture of the eroded rib. Uh, nerve block, if he is in agony, very good. I'm glad you mentioned that. It is a simple procedure. Intercostal nerve block, 1 minute, easier than doing an intramuscular injection. Give it immediate relief, but plan ahead. They need something like this. And if the patient has an gastric outlet obstruction, the best management may be a surgery, palliative surgery, a bypass. So let us not become so much interested in medications that we forget other factors. So believe the patient about the pain, correct the correctable, and make sure that the patient is adhering to the treatment. You have prescribed 4 drugs: morphine 4 hourly, diclofenac twice a day, or ibuprofen thrice a day, etc., etc. Patient may not be taking them because as soon as the patient took it home, the neighbor said, "Don't take that medicine; it causes severe pain in the tummy." They'll stop because the other person is speaking from experience. The way of asking about adherence to treatment is without sounding incriminating. If you ask, "Did you take all the tablets?" They will say, "Yes, madam," or "Yes, sir." And if you say, "How many times?" They will say whatever you mentioned because they are now scared whether you will scold. Instead, uh, hey, I want to make sure that you are taking all the medicines properly. Can I see that? Okay, this one. How many times are you taking this? When do you take the first tablet? Particularly about morphine. If you say 4 hourly, in their pain-ridden minds, they'll take it as 4 times a day. So, and when do you take the next one? And the next one? A minute spent on that is a minute well spent. And if they have made an error, I hope nobody will scold them. If you scold them, next time they will not tell you the truth. People are afraid of doctors. Instead, say, "Okay, it's very understandable that you made a mistake. There are so many tablets. Let me help you. Let us run through the list. Do an exercise." So, these are the first 3 steps in preparation. Let me tell you, this is not an official protocol or anything. We just created it within our team and we use it so that things are easier to remember. Believe the patient about the pain. Correct any correctables. check adherence to treatment. Ladies and gentlemen, do you have any questions, or can we go on to the next phase of review? Raju, please look out for the chat box.
No questions, sir.
And particularly in adherence to treatment, let me tell you, if you have prescribed expensive medicines, the poor will not take it because they don't have the money. And the rich, especially rich elders, may not take it because people of my age are scared. I don't want to spend a lot of money burdening my son. So just make sure that you are particularly asking for adherence to treatment about expensive medicines. Okay, now we are going to the review. We have already talked about the two kinds of pain. The nociceptive pain, which occurs by stimulation of the nociceptor or nerve ending, and the neuropathic kind of pain, which occurs by abnormal impulse generation anywhere in the nervous system. You remember when we started in the second day or something, we talked about only this one classification. Though pain can be classified in many ways. This you need to understand. Let me ask you, the person with the chest pain, the tumor is encroaching onto the pleura and causing pain. What kind of pain will that be? Nociceptive or neuropathic? There's no catch in the question. The obvious answer is the right one.
Nociceptive, sir.
Nociceptive, of course. And the rib erosion? Nociceptive. The pleural effusion? Nociceptive. The tumor erodes onto the brachial plexus and there is pain all over the upper limb. That is clearly a neuropathic pain. Pain is felt here. There is no lesion here. But abnormal impulses because of the abnormal nerve caused by tumor infiltration is generating abnormal electrical impulses which are going to the brain and here perceived as pain in the arm. That's a typical example of a neuropathic pain. Just taking another minute at reviewing it. Give me a few more examples of neuropathic pain. Not necessarily cancer, can be cancer also. Please unmute or speak or answer in the chat box. Examples of neuropathic pain. Abnormal electrical impulse in the nervous system.
Sciatica.
Sciatica, absolutely. A disc prolapsing or a malignant infiltration of the nerve roots causing pain going down the legs. Good. Anything else? Another example, please.
CRPS, complex regional pains.
Complex regional pain syndrome, absolutely. What we used to call reflex sympathetic dystrophy. Anything else?
Trigeminal neuralgia.
Trigeminal neuralgia, absolutely. Very good, thank you.
Peripheral neuropathy.
Any peripheral neuropathy, including diabetic neuropathy. Very good. That's a good list, like postoperative neuralgia and many things more. It can also follow trauma, damage to nerve plexus following a traffic accident and a crush injury. Now, you also notice that this can be in the peripheral nervous system or in the central nervous system. The examples that you gave were fantastic, but were all of peripheral neuropathic pain. Can you give me an example of central neuropathic pain? That means either in the spinal cord or in the brain.
Central pain syndrome.
Central pain, for example, following stroke. You have a stroke here. You have no sensation here, but you have pain there. Horrendous thing to happen. This can also follow spinal injury, pain in the paralyzed area. Those are typical examples. It can also follow tumors, typical examples of central neuropathic pain. I mentioned that because that distinction between peripheral and central may affect management. Central neuropathic pains are generally more responsive to tricyclics than to anticonvulsants. That's a general rule. Okay, shall we go on? We are still talking about reviewing the treatment. Depending on whether it is neuropathic, you are taking a second look. Can we modify our pain regime? Or is there a psychosocial issue worsening the pain experience? On our first day, I showed you the video of Smriti Rana talking about total pain. Do you remember that case history? The man had severe pain. He was concerned about his children's education. Morphine helped, but the pain really came down when he was assured of the children's education support. So, this is something that I would do. When somebody is not responding to treatment, drug treatments, I'll again look. There is something wrong here. Can it be an emotional situation? Is there something worrying the patient enormously? And you may find that that woman you have been treated has just been abandoned by her husband. I have seen this again and again and again. So, in reviewing the situation after preparation, you first look at the type of pain and see if your regime is appropriate. You look for psychosocial support, and we look for any other opportunities. I am very glad, doctor, you mentioned nerve blocks earlier. Those are the kinds of things that we should think about. It doesn't have to be the ladder and oral medication alone. Is there a nerve block possible? Can there be measures like what I've shown in the picture, a transcutaneous electrical nerve stimulator? On right at the moment, I am not going to spend time showing it to you, but that's only as an example. All interventions, including nerve blocks and non-pharmacological measures, massage, exercise, all these can help. And thirdly, you review the regime that you have been using. What is the nature of the pain? What painkillers have you been giving? Are they prescribed in the appropriate interval? Is there any adjuvants that you will have to rethink about? For example, paracetamol 500 milligram TID. This is for a patient who is 60 kilograms. Any comments?
QID at least?
At least 4 times a day. Thank you. Who said that?
Nirupa.
Thank you. Thank you.
Thank you.
But 4 times a day is good. Paracetamol 3 times a day is unacceptable for a continuous pain. It doesn't act for 8 hours. 4 times a day. And the dose, doctor? 60 kg person, 500 milligram. Is that
500
okay?
to 1000.
Should be 650 4 times a day or more.
Yeah, let us take this into consideration. We mentioned it once perhaps. Let me emphasize that minimum dose is 12 milligram per kg.
12 milligram.
So 650 is better than 500. If it is 60 kg person, I would rather give 1.5 500 milligram tablets. 750 may be easier. 4 times a day. That is quite safe. I have literature showing that even in the presence of a cirrhosis liver, unless the patient is in obvious hepatic coma, this dose is safe. Morphine 10 milligram Q4H, that sounds okay, except if the patient says, that's good, but after about 3 hours, I get the pain. It comes back. If they say that, it means that the dose has to be raised from 10 to 15.
50.
If the patient is getting regular morphine, bisacodyl will cause another case of pain if you give it only SOS. It has to be regularized every night. Gabapentin, if there is neuropathic pain, is that the right medicine? If it is so,
Yes.
if it is the right dose.
Yeah.
These are the issues. So what I mean is, when your initial ladder has failed, it is very good to sit down, look at the regime, and reflect on each medicine. And in future, when you have people with difficult pain issues, do please contact us. If you have doubts, Sunil, Arjun, me, we are all here, and we would consider it a pleasure to help you. Don't hesitate. Uh, I just now said gabapentin. We might talk about it more about the choice, but whereas tricyclics act in one way by decreasing reuptake of serotonin and norepinephrine in the inhibitory pathway, anticonvulsants work by membrane stabilization. That means, see, remember, I said that when there is an tumor infiltrating onto the brachial plexus, abnormal impulses are generated. Suppose you add a little bit of cement onto the nerve membrane surface, prevent the abnormal impulse generation. Of course, I don't mean cement. What membrane stabilizers like anticonvulsants, including your carbamazepine, sodium valproate, others, etc., do is to stabilize the membrane, prevent abnormal impulse generation within the nervous system. So, sometimes, even when anticonvulsants do not help, we use intravenous lignocaine. How many anesthetists in the group? You will find it easy, Dr. Rama, because giving lignocaine intravenously in the ward can be a dangerous game for somebody who is not familiar with it. Uh, so, intravenous lignocaine, I think every year there will be a half a dozen to a dozen patients in whom pain management is difficult, and we do this. If IV lignocaine helps, you may continue it for 3 or 4 days, but then you may switch over to antiarrhythmic agents. Flecainide is an antiarrhythmic agent that the cardiologist may use to prevent abnormal impulse generation in the conduction pathway in the heart. The same mechanism working on the nerve helps. Oh, I'm sorry to do this to you all. so much of pharmacology. I'm being very cruel, haven't I? What all did we say in review? Actually, prior to that, we talked about believing the patient about the pain, correcting the correctables, and checking adherence to treatment. Those were three things that we did in preparation. Then we went on to review about reviewing the nature of the pain and looking for a psychosocial issue also, reviewing role of interventional procedures and non-pharmacological measures, and reviewing the regime that we have been going, taking another look at it. And in that context, I said, if your routine neuropathic pain medications do not help, consider a second line of neuropathic medicines, including antiarrhythmics. Again, I am pausing to take any questions. The non-doctors in the group will find it particularly difficult. Sloga, I can see you sipping coffee. Coffee is not enough to overcome this kind of thing. Pharmacology. Any questions at all, or can I move on?
So do we titrate first with the IV lignocaine and we see the response and then switch over to antiarrhythmics, oral antiarrhythmics?
Doctor, that is not an absolute rule, but that is if the patient is in the hospital, it gives a good index because flecainide will take time to act. Lignocaine acts fairly fast. So if you give lignocaine, I can get the patient into the hospital, keep him for 3 days, put on a monitor, give him on a lignocaine infusion. Then I know whether it's going to work or not. Then I'll be more confident about giving flecainide. This is not an absolute must. Even without lignocaine, you can straight away go on to flecainide, remembering that the result will be seen only after a few days. Because in the hospital, if I give the IV lignocaine and it doesn't seem to work, tomorrow I can switch on to another step. Whereas here, I'll be able to switch on to something else only the next week. Have I answered your question, doctor?
Yes, thank you.
Shall I move on then?
Yes, sir. No questions are coming in.
Sorry?
Yes, sir. You can continue.
Okay. A little more about that neuropathic pain, something that I may have mentioned on another day, but I would like you to remember this. In neuropathic pain, currently, all over the country and possibly all over the world, the commonest drugs that are used are gabapentin and other gabapentinoids like pregabalin. Why? There may be many reasons, including they are effective, but I'll tell you what's the most important reason. They are expensive and pushed very aggressively by the pharmaceutical industry. Dr. Anil, in your whole career, no medical representative would have come to you asking you to prescribe amitriptyline, right? Why don't they? Because it's inexpensive, profit margin is low. Whereas you must have been bombarded with people trying to get you to prescribe their brand of gabapentin or pregabalin. But remember that WHO guidelines for a model list of essential medicines has taken it away. That if you go into this link, you will see the whole document. It will be those who have the time, please look at the WHO essential model list of essential medicines and also WHO guidelines for treatment of cancer pain. They have been taken away because their recommendation was based on fraudulent evidence. They have 5 publications to prove that the evidence submitted by the companies and studies were fake. The market for these medicines have been built on fake evidence. I'm not saying that they are useless, but first line, straight away go into these medicines is not good. So we are going to the next step. Uh, the third step of changing the treatment. Very sorry to do this to you. A little more about pharmaco uh, kinetics of morphine. You have given morphine to the man, 10 milligram 4 hourly, right? Okay. What happens to the morphine? It goes through the liver where it undergoes glucuronidation so that morphine 3 glucuronide, morphine 6 glucuronide, normorphine, and several other metabolites are created. Unfortunately, all of us do not react to it the same way. Me, Raju, Dr. Anil, Dr. Rema, and Sloga are all likely to react to them a little differently. About 20% of human beings has a different enzymatic pathway in the liver, so that some of us are likely to create more of M3G. And those who produce more of M3 glucuronide are likely to have more side effects. Others are okay. You increase my dose to 15 and I may start having delirium and I may be too drowsy. So we have no way of identifying who metabolizes it differently. We are not even 100% sure that M3 glucuronide is the cause. But it appears that some metabolite of morphine in some people cause more of neurotoxicity. Did you all get that? I'll repeat that statement. In some individuals, a different metabolic pathway in the liver causes abnormal reactions resulting in neurotoxicity to morphine, causing myoclonus, drowsiness, and delirium. तो क्या किया जाए? What can we do about that? Any suggestions from anybody? My pain relief is not enough. I am still saying no pain, and you increase it to 15 milligram, and I am delirious.
Can we add Finargan or something with 14?
Finargan or promethazine. Promethazine is a tranquilizing, minor tranquilizer, good anti-emetic, very good. I mean, a little sedative, but not enough of an antipsychotic. Dr. Anil, you're right in your line of thought that an antipsychotic like haloperidol might help. But then, already the patient is drowsy. Haloperidol will worsen the drowsiness. So that is one solution. May work. Any other way?
Sir,
Can
methadone?
we? Sorry?
Methadone?
Who said methadone?
Dr. Namrata Gupta.
Dr. Namrata. If morphine is causing a different kind of metabolite, switch to another opioid of the step 3. In our country, we do not have drugs like oxycodone, etc. The only other drug options we have are methadone and fentanyl. Methadone is inexpensive. If you start prescribing fentanyl right and left, you will cause a lot of suffering. Starvation in the family, unless your patient is rich. But methadone is inexpensive. We have not talked to you in detail about methadone. We are not planning to because it's a foundation course. Methadone is a little more difficult to use than morphine. It is more difficult because the margin of safety is narrow between therapeutic dose and side effects. So again, this is something that we will help you with. We will help you with procuring methadone and with making it available to you and guiding you how to use it. So what was I saying? We are saying that if your preparation and review are over, you feel to change the medication, one thing you can do is what's called an opioid switch, switching from morphine to another one. In a small number of patients, this may be better. There are other advantages for methadone while there are disadvantages. Today, I am not going to the details of methadone. Here is another way. If all these nuisance factors are developed in the liver, can we bypass the liver? If you give the morphine to me parenterally, then only a little bit of the morphine will go to the liver, right? It is not getting absorbed and going straight to the liver. Remember, people who do not tolerate oral morphine very well may well tolerate parenteral morphine. But administration of parenteral morphine in the home setting is difficult in India. In Sloga's country, if a patient needs parenteral morphine at home, a district nurse will go to the patient's home, set up a syringe driver for 24 hours, go back every day and change it. We cannot. We do home visits, but we never visit patients more frequently than once a week. Even that is difficult for us. So we here can do two things. One, we can put the patient in as inpatient and use it. Two, we sometimes do it if we have reliable people at home. We'll put up a butterfly needle, fill one syringe, 20 ml syringe, arranged in such a way that 1 ml is one dose. Tell the family, just push in 1 ml every 4 hours. And after 2 days, the son or the husband or the wife comes back with the syringe, takes another syringe. Please do not send ampules to patients. There is no law against it, but that is risky. Risky in several ways. Risky that it may get sold in the black market, unlike oral morphine. Oral morphine is not in great demand. It doesn't give a kick like injection. So, two measures I have given you. One is switching from morphine to methadone or fentanyl, and the other injectable morphine. Now I have to, how are we doing for time? 3:40. 5 minutes on this, treating central sensitization. How are you all coping with all this pharmacology? Raju, can you take a quick look around and wake up anybody who is sleeping already?
Most of the videos are on off, and those who are on
Okay. So,
are sleeping.
okay, let them sleep then. So those who are up, we are going to talk about central sensitization. We talked about it once. Then I introduced pain to you on the second session, I think. We talked about central sensitization. That happens when pain has been severe and is unrelieved for a length of time. Like this chest pain and the rib erosion and the neuropathic pain. It has been with me for 3 weeks. Whatever was given to me was not adequate. So what happens? The impulse generation from the nervous system keeps on increasing. I told you. The body now tries to give you more pain and more pain. Run away, run away. There is danger. That's what the body is saying. You can't run away from the cancer. But the body doesn't know that. It sensitizes the nerve endings. It causes recruitment of silent or sleepy nociceptors, but it also causes sensitization of the dorsal horn cell. So that every impulse now coming from here causes multiple impulses to go to the brain. Tens and hundreds of impulses will now go to the brain in response to every impulse from the periphery. This is an oversimplification. This is not the only thing that happens in central sensitization, but I'm not going into the detailed pathophysiology here. How can we treat this central sensitization? Because now you are going in 3 weeks later, already the dorsal horn cell is sensitized, and now your morphine is not good enough. Anesthetist in the group maybe be able to tell me about some way of treating central sensitization. The neurotransmitter involved in the process is N-methyl D-aspartate, NMDA. NMDA activity is the predominant reason for causing dorsal horn cell sensitization. And all the anesthetists know of one anesthetic agent which causes NMDA blockade.
Dr. Kevin says ketamine.
Dr. Praveen, absolutely right.
Kevin.
So, Dr. Kevin, your anesthetic agents called ketamine, Ketamine, does treat central sensitization. There are a few other things that may help it, but NMDA is most potently overcome by ketamine. So what you do, Dr. Kevin, of course, is not to give the anesthetic dose for a patient 50 kg. If he is to be, anesthesia is to be induced, Dr. Kevin may give this dose, 100 milligrams to 250 milligrams, just once in one bolus. Here we give this over 24 hours as a slow infusion. And usually that is induced, that is continued for 3 to 5 days. So a subanesthetic dose is given as so-called ketamine burst therapy over several days. Sunil has used it in several patients. And Sunil, would you like to tell the group what is the commonest adverse effect that you have noticed?
For methadone? Sorry, for ketamine, okay. So actually there are no much side effects, but sometimes patient might have some nausea, vomiting, sometimes some hallucinations. And
Wait, Sunil. So already important points made. It may cause nausea and vomiting. So just as you give morphine, it may be a good idea to start with an antiemetic. 2, he mentioned, sometimes it causes hallucinations. It has a narrow margin of safety. It causes psychotomimetic side effects. The earliest may be lightheadedness. I don't know what's happening, but I have an odd feeling. That's what they will say. Then they may get sleepy. But the worst thing is, that's what Dr. Kevin will find in the operation theater when they wake up. But here it may happen during this therapy also. They will see things that do not exist. What Sunil mentioned was hallucinations. That means the dose is way above what is tolerated by the patient. So when you start with a small dose and the patient feels lightheadedness, you should reduce the dose. You shouldn't increase it. Hallucination would never happen. So, Sunil, sorry, you were about to say something else?
Rarely the some other side effects which is serious is liver toxicity and hemorrhage, sometimes cystopoly also.
We'll come to that. Thank you, Sunil. Oral ketamine can be given. To the best of my knowledge, oral preparations are not available in the country. What we do is take the injectable medicine, mix it with a sweetened drink, tea, coffee, or fruit juice or something, and then give it. I have given the dose there. I'm not going to talk about the dose now. You will have the presentation later. So you can look it up, and especially those who are not anesthetists, if you feel the need to do this, do please contact Sunil or I or one of us, and let us work with you. As I said, narrow margin of safety, care used has to be careful. And it has a place, especially in developing countries. In Western countries, they don't use ketamine much because of the hallucinations. They are very, very worried about medical legal implications. There has even been a case of alleged rape to a doctor by a patient. And fortunately, there was a nurse witnessing the whole sequence. Therefore, the doctor escaped. So it can be used, but carefully. The risks that can happen that Sunil was mentioning, not very common, but does happen. Sunil, even last week or week before last, you used ketamine on somebody, and the enzymes were going up at the end of 3 days.
Yeah.
I forget who it was. So it is not all that uncommon. If you find that SGPT is going up, we should stop ketamine. And another side effect that Sunil was mentioning is vesicopathy. Symptoms like cystitis. The same patient that we had after the 3rd day also complained of burning in the urethra, and we had to stop the ketamine. So these are some side effects of ketamine, and how we came into that, if you remember, is by discussing NM central sensitization and NMDA blockade. So with that, we have gone through the 9 steps. In the first step, we mentioned prepare, believe the patient about the pain, correct correctables, check adherence to treatment. And then we said, look for psychosocial factors. Is there any interventions or non-pharmacological measures that may help? Should we review the choice of medications that we have used? And then we said we'll try opioid switch to methadone. We'll try a different route of administration like parenteral. And we'll try, in appropriate cases, use of ketamine for central sensitization. Okay. I'll take your questions, but first I have a question. You are not going to succeed in every patient. Despite doing all this, we still sometimes fail. In 5 to 10% of patients with cancer, and in a higher number of patients with other pains, you may still fail to achieve satisfactory pain relief. And we, you and I, have to be ready to accept that. That's my step 10, acceptance. If it is a patient with cancer and the patient is near death, we may consider palliative sedation. I'm not going into that now. Make the patient sleep as long as possible so that they don't feel the pain. But if not, this is critical. Never desert the patient. I may say, I'm sorry that everything I have tried has not given you pain relief. Sorry. I'm sorry that it is so. But we are here to support you. If the pain gets worse, please come back to me. If you need to talk to somebody, please come back to me. We'll continue the medications that are giving you some relief, and we are here for you, even though we have not been able to treat your pain enough. Ladies and gentlemen, that's a very, very important message that I have to give you. Whenever in any situation in palliative care or in any medical care situation, do not desert patients. You have been kind to them. They look up to you. They will tell you, Dr. Kanagasabha, you are God to me. Please do something. And Dr. Kanagasabha may say, we will continue to do everything that we are doing. I'm sorry that we are not able to treat all your pain adequately. But whatever I can do, I am here to help you with. That's our message. I think I'll stop there and take any questions. Sunil, over to you.
Yes, sir.
If during the discussion it is necessary to come back to the slides, I am happy to come back to them.
Are there any questions? Any of you have treated any patients with chronic pain? Anybody, it need not be your questions or comments, but your experience also you can tell.
No questions and comments at all. But from Dr. Rama's look, I think she was about to ask something. No, Dr. Rama?
Any of you have used ketamine for chronic pain? No?
Sunil, there are no questions, and we have 3 minutes. So let me tell everybody Pathu's story. Pathu was a patient with intense neck pain. She had a severe cervical spondylosis and calcification of the ligaments. And surgical treatment, the doctors were reluctant because the complication rate would be high. And whatever we did, her pain did not come down below a certain point. I am now talking about my step 10. So Pathu was a very poor woman, and by no means rich, and life was very hard for her. And now, with severe pain over a long time, her son was also getting fed up with her, always getting angry. So, the things that I did when we were through step number 9, one was to have a discussion with the son. I did not advise him, I listened to him. I listened to his difficulties. He did 90% of the talking, and then I did the 10%. I said, I can see you are suffering. You love your mother, but you still feel irritated with her. I told the son, you and I have to accept that she will live with some pain, that she will be irritable, and you will be irritable. That may be okay. But when you snap at her, later on, go back to her and say you love her. And when I said that, he cried. Then I had another discussion with Pathu. I told her, Pathu, whatever I have done, you have not had any significant relief. It has been very little. Pathu suddenly jumped up, held my hands, and said, please don't tell me not to come back. This is the only place where people are kind to me. I need to come back to you. So she was afraid that I was going to say, you don't have to come back. That is fellow travel. Traveling with them, Pathu and her son had very difficult journeys to travel. And I, as a pain therapist, was failing. But as a human being, I could still give them companionship. So I am stopping that session on difficult pain with reminding you that we are doctors, we are specialists, we may have many degrees, but fundamentally, we are human beings with the privilege of being able to help these people. And when we are unable to help them with our medical expertise, we can still help them with our humanity. Thank you.
So, thank you, sir. So I would like to give you one example of opioids which has happened or which is happening now at our IP. So this is a young patient, 31-year-old male, and with the carcinoma of the tongue, and he was on morphine. Started with 10 milligram, and it increased up to 50 milligram, 50 milligram 4 hour day. But still he had very severe pain which starts from angle of the mouth and it radiates to head, on one side, and he was also on tricyclics with optimal dose. And the main problem the caregivers were reporting was the patient is very much angry. He doesn't face anybody. He's always in a room. Whenever somebody talks to him, he is angry. That's what the caregiver says. So we asked him to come, and we switched over to him to methadone. Uh, so with methadone, he had complete pain relief within 2 days. He had complete pain relief, but he was drowsy and he was sleepy, so he didn't take it. So he was admitted, and now he's on a lesser dose of methadone, but he has good pain relief. He is not angry at all, and he says he's happy. Previously he didn't had any eye contact with anybody, but now he looks at us and talks normally. So this is an opioid switch which has happened recently. So it is methadone is very useful in selected patients.
Oh, that was excellent example, practical demonstration. Thank you, Sunil.
So I think we can move on to patient story. So today's patient story will be presented by Dr. Navish David from Christian Medical College, Ludhiana.
Hello, am I audible?
Yes, Dr. Navish.
Very good evening to everyone, and thank you, Dr. Raja, for wonderful session. It was really enriching, enlightening. There might be some network issues on my part because there's some farmers agitation going on, and these people are after geo towers. So unfortunately, I'm using geo network connection. Okay, so I'm going to tell you a story about a patient, 29 years old, male, with the diagnosis of seronegative spondyloarthropathy with bilateral total hip replacement. So let's discuss the presenting complaint. So this gentleman has had pain in bilateral hip joint for almost 8 years, and along with that pain, along with swelling in bilateral knees for 8 years. The swelling later turned out to be effusion, joint effusion. Along with that, he also had pain and swelling in wrist joints for almost 8 years, and pain in shoulders, bilateral, for 8 years. So for 8 years, this gentleman has been suffering from pain, which ranged between mild to moderate, and at times it became very severe. Coming to the history of presenting illness, a patient was apparently well 8 years ago when he started developing swelling in his knees, along with pain in lower back and around hip joint area. So before this started, patient gives history that he had an episode of severe fever once, along with loose stools. So that pointed out to be kind of reactive arthritis. So initially, the patient took some non-steroidal anti-inflammatory medications to relieve the pain, but that didn't help him much. The pain gradually increased over the years that he started to walk with a limp. He went here and there, but nobody could actually give him a diagnosis. The final diagnosis was made as seronegative spondyloarthropathy from CMC Vellore, which is a diagnosis of exclusion. When you have ruled out everything, then they narrow it down to seronegative spondyloarthropathy. So examination-wise, general physical examination was normal. Systemic examination was also normal. On local examination, there was swelling around both knees, There was decreased range of motion in knee, hip joints, and shoulder joints. Along with that, there was shortening of right lower limb by 2 centimeters. So coming to investigations, blood reports were normal with slight hemoglobin being on the lower side. HLA, ANCA, PANCA, all rheumatoid panel, autoimmune panel was negative. X-ray showed advanced arthritic changes in both bilateral hip joints, shoulder joints. CT scan showed sacroiliac joint showing inflammation. And MRI hip joint showed advanced sclerosing, advanced joint destruction of cartilages of hip joints. So treatment, the patient over the years tried many treatments. Started with basic NSAIDs, aceclofenac, diclofenac, indomethacin, ibuprofen, then tramadol, and then someone suggested amitriptyline also might help you, low dose amitriptyline. Along with that, he was started on DMARDs, Sazo and methotrexate. He even had trials of course of infliximab once and etanercept, but none of these things actually helped him. So coming to psychosocial aspects, patient felt very sad because he was now unable to walk properly. His mobility was compromised. And when he saw his friends enjoying life, running, playing, he always thought to himself, will I be ever able to do that? Patient felt worthless, hopeless, as the pain increased gradually over the years. He was deep down afraid that due to his problem, nobody would marry him. He was a young man, so these kind of things generally come to them. He knew that there would be gradual destruction of all his joints due to his autoimmune nature of disease, which might lead him to a wheelchair. And he's afraid of being handicapped for life and being a burden to his parents. He had resorted to excessive consumption of alcohol, smoking to escape the reality. Patient also started to consume marijuana to divert his attention from the problem at hand. We can call it escapism. Patient over the course of time became very irritable due to chronic pain. His relation with his father was not that great. And chronic pain had changed his behavior, his personality. And he thought nobody could actually understand what I'm going through because the maximum pain was in the hip joint. And whenever he used to make excuses to his fellow colleagues that I'm having pain, could you do this work for me? So everyone thought that this guy is making excuses. So due to that, he had to endure the pain and exert too much. Now, due to unstable emotional thought process, patient quit DMARDs and all his medication and even contemplated permanent suicide as a permanent solution. Patient was very apprehensive about the surgical option, which was the final option given by the doctor because walking was becoming a challenge day by day. And furthermore, post-op pain was like very, very unbearable or difficult pain. So coming to medications, the patient finally underwent bilateral total hip replacement in one sitting. The post-op medications which were given in that hospital were codeine tablets 3 times a day, but that didn't help him much. Post-op epidural catheter was placed and pain pump was started. Only after when the patient was screaming with pain, when the effect of the anesthesia worn down, and the pain was really 9 or 10. And this epidural pain pump caused urinary retention, which further aggravated a different kind of pain in his lower abdomen. But it was finally relieved by urinary catheter insertion. But by the time the palliative anesthetist on duty pain clinic people came, he already had suffered too much of urinary retention pain. By default, anti-inflammatory was purposely not given post-op. So coming to main concern, young patients suffering from chronic pain with debilitating arthritis. He's apprehensive about his future as a major surgical procedure was about to be undertaken. And sooner or later, he knew that slowly his knee joints will give in, his shoulder joints were in really bad shape. He does not want to become a burden upon his family. And then the final question is, who would marry him? So to summarize, a young patient was initially fighting chronic mild to moderate pain. Post-op, primarily, he was in need of immediate pain relief, and the post-op pain was excruciating. Pain was not being controlled by codeine tablets, as codeine tablets are the only thing available in Punjab. Pain had become unbearable as the effect of anesthesia wore now. But once the epidural pain pump was started, there was immediate relief of the pain, but then it had caused urinary retention. So discussion points. Emotional pain, physical pain, and psychosocial.
Thank you, Dr. Navish.
Yes, sir.
So we have a young patient who is suffering from chronic pain, and at last he underwent bilateral knee replacement. Bilateral hip replacement.
Total hip replacement.
Total hip replacement. And how these aspects can affect the pain, and how can we manage physical pain? So I request anybody to comment on this. Anybody? So Dr. Navish, Dr. Dheeraj is asking about HLA-B27.
Yeah, HLA-B27 was negative, as I told you. Seronegative label is only given when everything is negative.
Yeah.
But there is apparent clear-cut autoimmune inflammation in joints. So HLA-B27, all HLA profile, everything was done. Everything was negative. Biologics were started, but that didn't help in reduction of pain. So what happened was these episodes of pain, sometimes very bad episodes, really kind of put him in a depressive mood. So he discontinued his DMARDs, Sazo and methotrexate. He never took any medication regularly. That was maybe that's a fault on his part.
Okay, Dr. Bhargavi says epidural should have put in immediately after surgery, so that he may not have suffered the acute pain due to surgery.
Yeah. That initial pain was a very difficult part.
Sir, would you like to comment on? Yeah, you are muted, sir.
Sunil, thank you. And everybody, um, thank you, Sunil, for giving me an opportunity, because I will have to leave it in another 4 minutes. 4:20 I'll have to go. So I'm glad to have this opportunity to talk. So the re- reactions that came in so far from Dheeraj and Bhargavi were very good questions to solve the problem. I totally agree. But maybe at some point in an institution like CMC Ludhiana, excellent facilities are there. So maybe I'll also start thinking they have done everything that is possible to address the disease. Maybe a little bit of this way or that way might have been possible. But here are major psychosocial issues. Let us go back to our three-step thing in our preparation. What all are we going to check? Certainly, we'll check the drug therapy. Let me ask you, can we give morphine? Did codeine help even a little bit? In which case, morphine might have helped. Would you be willing to get him started on morphine? Let me give you the answer because I have very little time. Morphine will be the last resort, particularly considering his history of alcohol use and cannabinoid use. This is a person with the pain, with everything, has a potential for drug dependence. So, if he was not in Punjab, if all the conditions are discussed and no other option is there, I might enter into a contract with him, which in Western countries need to be written contract. In Western countries also he has to subject himself to urine analysis to make sure that he is not exceeding the dose. But here the contract says he will get only the prescribed quantity. If on Wednesday he comes back and says, I have lost my tablet, give me some more, you will not get it. This is to protect him. What I am saying is, even if somebody has a history of drug addiction, even if it is non-cancer pain, certainly opioids should not be the first line. Opioids should not be the second line. But if there is no other go, you prescribe opioids with clear understanding with the patient and family, with strict restrictions on the quantity that is dispensed. One, our preparation also included looking at the psychosocial factors. Many other things that I drew parallel, except in the case of Patu, were about people with cancer problems. In non-cancer problem, behavioral disorders are inevitable. His irritability, his hopelessness are all understandable. His family will start getting angry. They will develop compassion fatigue. They will be irritable too. There will be more frequent fights. There will be attempts at suicide. These are all things that I see in future. Apart from the various medications that can be tried, which you may continue with Sunil before I leave, the only thing that I tell you it was what was given in my last slide. Remember, here is a gentleman for whom not even his family may care enough. You are the only person to give him human love. He will have his behavioral disorders. He will be manipulative. He will come and say, Dr. Navish, you are God. You are God. Nobody in the world cares for me. You are the only one that cares for me. Thank you very much. I want to touch your feet. And Dr. Navish, I'm sorry. The pain was so agonizing yesterday that I had to take tablets more. And I want you to give me some more. And Navish will have to remain compassionate will have to remain calm, will have to be firm also and say, sorry, gentlemen, I care for you. I'm sorry to see you suffering. But remember our contract. Under no conditions can I give you more than was prescribed. But you are not rejecting him. He will come back to you and you give him human love. He may never get married. And even if he gets married with this condition, it's very difficult for him to have a normal conjugal relationship. I don't mean only sex, but also behaviorally. We will have to go with him, whatever is his decision. And on final point, very, very unfortunately, Punjab is one state in India where opioid access is most difficult than anywhere in the rest of the country. Sorry, ladies and gentlemen, I have to go now. I leave you to Sunil. Sunil, thank you very much. Everybody, thank you.
Okay, thank you, sir. So, what is the natural history of this disease? Anybody knows? Anybody? Dr. Naveen, do you know?
I didn't get the question. Sorry.
What is the natural history of this disease? Spondyloarthritis.
It's an autoimmune disease. It's similar to ankylosing spondylitis. But in ankylosing spondylitis, you have HLA-B27. But in this, if it's HLA-B27 negative, then you cannot label it as ankylosing spondylitis. You label it as seronegative spondyloarthropathy.
So is it going to affect other joints also?
Yeah. It's a polyarthritis. All joints are involved. Basically, it differs from person to person. In some people, large joints are only involved. In some people, large joints plus small joints are involved.
And pain is also like that, isn't it?
Yeah,
sometimes
pain is
it aggravates, sometimes it comes down.
Right.
And it not only affects the joints, it can also affect, I think, heart also.
Yeah, if it's a combination with the uveitis and cardiac involvement, then we label it as other syndrome. Yeah. But autoimmune can affect anything.
Yeah. Okay. So why I asked whether it can affect other systems also, because right now he is able to walk because of, isn't it?
Yeah. Now he's completely mobile.
Normal. Yeah.
But other joints are still involved.
So we have to actually the natural history of the disease, whether actually we should check the insight of the patient also, what he knows about. From what you have described, I understand that he knows fully about the disease. That's why he is worried about marriage and things like that.
Yeah.
So here, as we don't have any other medication to cure it, but maybe disease modifying agents might be helpful to delay the progression. So maybe actually I haven't seen such a patient, so I'm not sure about the natural history. How long will he live, and what other complications?
It's similar to, you can say it's similar to a severe rheumatoid arthritis.
Okay.
Because in rheumatoid arthritis, we've seen hip joints getting destroyed.
Yeah, and many patients they linger due to pain, rheumatoid arthritis, even with disease modifying agents.
Yeah.
So this is something which we have to give him companionship because as sir told, he is already uh, having psychological dependence to alcohol and marijuana. Is he still
Yes.
consuming that?
I don't think so.
Okay. But with a history of dependence on alcohol and marijuana, then we have to actually need to be careful because on opioids he can have psychological dependence. That's what
Yes.
sir was saying. Morphine should be the last resort for pain management. And I just want to comment on the codeine because codeine, how much he was getting? Any idea?
I
You told
think
it
it
was
was,
serious.
yeah, it was, I think, a 10 mg, 10
Okay.
mg TDS.
Actually, morphine can be increased. Codeine, the dosage can be increased. And actually, it has to be given at least 6 hourly. So it is 1 by 10 as potent as morphine. But compared to morphine, codeine is more constipating. And some patients actually, codeine may not be metabolized to its active component because of the genetic polymorphism of cytochrome P2D6 enzyme. So we don't know whether it was due to the genetic polymorphism or is it due to the reduced dose of codeine he didn't have generally. So that is one thing which we have to check. And actually we can go up to 360 milligram per day. Um, uh, and even more, but the problem is it is more constipating. And many people may not like to take codeine. Nowadays, codeine is not used by many people. Previously, I have used a lot, but now we don't use. We use even low dose morphine or tramadol. Uh, yeah.
Yes.
So, do
In
you have
Punjab,
tramadol?
tramadol, yeah, tramadol we have available. Again, it's highly regulated because tramadol abuse is on the rise after codeine was banned, Corex was banned.
Tapentadol?
Tapentadol, yeah, I have seen people prescribing it. I think it's available.
Yeah, it's still a step 2 opioid, but it is more potent than tramadol, but not amounting to step 3 medication, step 3 opioid. So maybe in your situation you have to manage with tramadol or tapentadol along with any other help from your physiatrist. Maybe
The problem, one more issue is that I don't know whether if you've seen the movie Udta Punjab. The problem of opioid abuse is very, very common. You go to any home in village, everyone will have some form of opium because it's part of culture. People use it as medicine. If somebody gets stroke, they give some opium. It's a very old practice. We've come across so many people.
Yeah.
So opium is easily available because the nexus is Afghanistan, Pakistan.
And Afghanistan, I think it is
smuggled through border.
Yeah.
So it's very, so in Punjab, we have this, this problem is opium is very prevalent. And more or less, if we come across some people, everyone will have some past history of opioid interaction. So that will become challenging for us in Punjab.
Okay, so definitely the points you put out, the psychosocial and psychosocial problems and even the financial problems, it is going to actually going to affect the patient because he knows that he has a chronic disease which is not curable. So in such situation, I think we have to talk to the patient more, and he has to feel that we are with him. and we are a companion to him. And when he comes to you, he will give you some pain relief. But when he goes to any other people, they will be looking at him like a addict. So he was using alcohol and marijuana. So that will be the attitude of many other doctors, and he may be rejected by the other people. So don't abandon him, and let him come, and we have to do as much as possible for us, uh, keeping in mind that the addiction can still be there. And I think he whenever we go through the through a loss or the immediate loss which can happen in his case, uh, he has an incurable disease. So he may go through Elizabeth Kubler-Ross model of grief, like denial, anger, bargaining, depression, acceptance, etc. So he may come into a stage where he accepts that he has an incurable disease and he has to live with it. And then only he can actually adjust to the present situation.
Right.
Anybody else have any more comments?
Is there any role of steroids with this? Maybe because all around inflammation.
Steroids was given to this patient.
I don't think you mentioned it. Huh?
But it was stopped. It was initially started, but it was stopped because they didn't want the arthritis to become steroid dependent. Once it becomes
Were there
steroid dependent.
any, like it was all throughout the year, or were there any seasonal changes in the pain or something like?
The pain was mild to moderate, but it was excruciating or severe if he overexerted. And he had to overexert because nobody could actually understand the pain he was going through. Hip joints didn't have any swelling, so nobody could understand. There's a pain, joint destruction going on inside. So,
does steroids give him pain relief? Any idea?
Yeah, it was started. It gave him pain relief, but it was stopped by other doctors.
Yeah, I know there is this thing, risk of concomitant avascular necrosis and all.
Yeah, and sometime local steroid injection into the joint or with the local anesthetic can help to reduce the pain. So a physiatrist would also be able to help in this situation, I think. Anybody else has any more points?
But I think with the joint replacement now, he's mobile. He should be able to work and maybe accepting that mild to moderate pain, with which he can maybe controlled with tapentadol and all. He can go about his work.
Yeah, actually, we had a patient, young patient, 35-year-old man, who had a fracture of radius and ulna. And then after some time, he had complex regional pain syndrome. He had very severe pain, 10 by 10. And he was put on many medications, which were not giving him pain relief at all. And then we actually started to give a steroid ganglion block, and which gave him very good relief. But he has to come every month. So once it was performed, that was gone intravenously, and it caused convulsion. And he had to be put on ventilator. And thereafter, he was not willing for stellate ganglion block, but still he used to come to us for visiting us every month. And but his pain was same. He had very severe pain, and after some time, we were continuously following up. And once he came and told us he's happy now. So I asked him, how is your pain? He told pain is same. Pain is very severe, but I learned to adjust to the pain, and now he's living a normal life. So this is what some people will do. They will adjust to the pain, and they will try to live with it. So this is something which I want to tell you, because I haven't seen such people in my life. So I think Dr. Navish, shall we wind up the session?
Right, sir.
So thank you, Dr. Navish, for bringing up that chronic